Good morning, everybody. Thank you for coming for this symposium session. This is a very unique session, and Deglutology is basically the science of swallowing physiology, dealing with swallowing disorders and its management. And we have three talks today. One is neurogenic dysphagia, surgical deglutology, and also rehabilitative swallowing therapy. Basically, the first talk will be neurogenic dysphagia. It's neurogenic dysphagia, the etiology is very multifactorial. There are a lot of etiologies, and each etiology depends on the neurological issue which is causing the dysphagia. So it's more of a syndrome than actually a symptom. And it does have a lot of morbidity, a lot of mortality it could lead to, and also a lot of social costs for the patient and the carer. So to start off with, the first topic of the day would be neurogenic dysphagia. It will be a talk given by Dr. Farah Kazi. I welcome chairpersons who will be introducing the speaker, and also on the outside I want to thank Professor Ali Sultan, Dr. Nagaraj, Dr. Balakrishnan, and the rest of the organizing team for coordinating this symposium. Thank you. Sir, please do introduce the speaker, sir.
Good morning. Welcome all to this interesting session on deglutology. Dr. Vidya is a known face in this part of the country, and head and neck surgeon for more than 10 years, and he's a very skilled robotic surgeon, and he's based in Chennai, and we have known him well for quite some time now. And I would like to invite the speakers for this session. Dr. Farah Kazi. Welcome, ma'am. I would like Vidya to do the honors for the speakers.
Sorry for the confusion. So, Dr. Farah is a upcoming renowned gynecologist in Mumbai. She is also a voice specialist, and she has a special interest in swallowing and recently trained from Professor Bellasky in California. And she is a consultant at Medicover Hospital, and she also has her own clinic in Mumbai. I welcome Dr. Farah.
Thank you very much. It's an honor to be here today, to be speaking on something that I really love talking about, which is dysphagia. Today we'll be discussing about neurological dysphagia. In order to dwell more into neurological dysphagia, it's very important for us to understand what a normal swallow looks like. A normal swallow is a complex integration of a number of sensory motor information presented to the brain. It's partly volitional, that is partly it is voluntary, and partly it's reflexive, that is it is controlled by the brainstem. Generally, it is thought of as being divided into three broad phases: oral, pharyngeal, and esophageal. The main purpose of swallowing, or the main swallowing event as an ENT, is for us to assess how is the airway protected during swallowing, also what is the efficiency of clearance of the bolus from the oral cavity passing through the pharynx into the esophagus. Normally, pharyngeal swallowing takes approximately about only 1 second to take a sip of water. Did we even think about that when we swallowed? The central nervous or central swallowing system is broadly classified into cortical, subcortical, and brainstem mediated centers. There are n number of centers that are involved in controlling swallowing, from the cerebral cortex, the subcortical areas, the brainstem, and the cerebellum. The areas that are involved in the cerebral cortex mediation are the primary and the secondary sensory cortex, the primary motor cortex, and the lateral and the medial premotor cortices. Some information also comes from the limbic system. The main center for swallowing is the pontomedullary swallowing center, also called as the central palatal generator. There is some control and coordination also from the cerebellum. So what's the role of brainstem in mediating the pharyngeal swallow trigger? There has to be a sensory input, either in the form of taste, in the form of touch and temperature, once the food enters the oral cavity. The bolus stimulates n number of afferent signals from the afferent cranial nerves, reaches on to the pontomedullary center, which is formed by the nucleus tractus solitarius. That further signals onto the motor nuclei in the nucleus ambiguous to initiate the swallow. So the result is the pharyngeal swallow response. Now this response is an all or none response. The brainstem swallowing center contains the central pattern generator, which forms the core of the system. So a normal swallow, I'll just be brushing through, starts off with an oral preparatory phase, which is completely voluntary, which is aided by the trigeminal or the fifth nerve in chewing, the ninth and the seventh nerve for salivary secretions from the parotid and the submandibular gland. The muscles involved are the mandibular elevators and the depressors. Moving on to the oral phase, which is again voluntary, which is aided by the seventh nerve or the facial nerve, which forms the labial seal to not allow any kind of dribbling when the food or texture is into the oral cavity. Also aids in taste sensation. The 12th cranial nerve for the anterior to the posterior bolus movement. The muscles involved are the orbicularis oris from the facial muscles, the intrinsic and extrinsic muscles of the larynx, of the tongue, sorry. Moving on to the next phase is the pharyngeal phase, which is supplied by the 5th cranial nerve for the soft palate closure, which forms a seal, the 7th cranial nerve for the laryngeal elevation, the 10th cranial nerve for the laryngeal velar closure and pharyngeal constriction, the 11th cranial nerve for the soft palate closure and pharyngeal constriction, the 12th for the laryngeal elevation again. Moving on, it causes soft palate elevators and depressors are innervated by this, the intrinsic laryngeal muscles are acting, the supra and the infrahyoid muscles, and also the pharyngeal constrictors. The next phase is the esophageal, wherein the upper esophageal sphincter, which is supplied by the 10th cranial or the vagus nerve, and also aids in the esophageal peristalsis. The most important muscle here is the cricopharyngeus muscle, along with the other esophageal muscles. So what are the neurological disorders causing dysphagia? There are many. And what is the most common is a cerebrovascular event or an accident, also called as stroke, which we commonly see in our OPDs or also in the ICU setup. The next common cause for a neurological dysphagia is a traumatic or a global injury to the brain. The other common causes are neurogenic diseases like Parkinson's and amyotrophic lateral sclerosis, which are progressive neurodegenerative conditions. The others are myasthenia gravis, Guillain-Barré syndrome, infections, neoplasms, and metabolic disorders. Today we'll discuss in detail about the most common etiology, which is stroke. So what's the overview of the post-stroke dysphagia? Now dysphagia affects approximately 55% of acute stroke patients who are admitted to the hospital. Over a period of 2 to 3 weeks, this incidence of dysphagia reduces to about 20% then. Now these patients are 3 times more likely to develop pneumonia as compared to stroke survivors who do not have dysphagia. And there is a higher mortality of stroke patients with dysphagia in first 90 days after stroke. So does the side of the lesion matter? Now swallowing motor functions are bilaterally represented in either of the hemispheres. So if a dominant hemisphere is impaired, the contralateral hemisphere can act as a backup to facilitate recovery in such patients. That's the reason over a period of time, say 2 to 3 weeks, dysphagia automatically comes under control. Now this is because of cortical or neuroplasticity which occurs over time. Now does the size of the lesion matter? Really not. Now the lesion size and dysphagia are not in a very perfect linear relationship. If the crucial region that is essential for swallowing is lesion, it does not matter if the overall lesion is very small. For example, if there is a small lesion in the internal capsule, say very little, less than 5 ml, that can lead to severe dysphagia. Now what are the characteristics of swallowing impairment that we see in patients after stroke? They are broadly divided into supratentorial and infratentorial structures. So the supratentorial structures are nothing but the cerebrum, that is cerebral cortices, and the subcortical area, that is the deep intracerebral lesion. And infratentorial are the main hero sitting out there, which is the brainstem and the cerebellum. So in a case with hemispherical CVA or a stroke, the features that are seen are, there are two important studies that we do as an ENT to diagnose dysphagia other than taking a clinical decision. One is a video fluoroscopic swallowing study. The other is a fiber optic endoscopic swallowing study. This is the image or a video of a video fluoroscopic swallowing study of a patient with a hemispherical post-stroke. Notice that the bolus is in the oral cavity. The patient is making all efforts to move the bolus down into the pharynx, but the bolus does not pass through. That is because in cerebrovascular accidents in the hemisphere, there is a delay in initiation. Number two is lack of sensory recognition. That is, once the bolus reaches into the pharynx is unable to identify the presence of the bolus into the pharynx. There is a lack of organizing or reorganizing of the initiation timing. Quite a lot of residue remains undetected with the patient is not able to understand and swallow again. Sometimes these patients can have episodes of penetration and aspiration, like it's happening in the patient out here. This is the pharynx through which the bolus is passing through. Do you notice the amount of dye that enters into the airway and the patient goes into coughing? Now similar patients, when we do a feast, what we notice is a lot of pooling of secretions and also the food that we are given to the patient onto the laryngeal inlet. The patient has not identified that there is a bolus that is entering into the pharynx, subsequent to which some amount of material, specifically liquids, enter into the airway and there is presence of aspiration. In some patients is the presence of the pharyngeal residue. Here both the vocal folds are mobile. The patient has absolute okay voluntary sensations but absolutely no pharyngeal sensations. Directly most of the liquid that is taken off goes into the laryngeal inlet. Number two, the brainstem CVA.
Fantastic talk, Dr. Farah. A few questions. Most of the patients, the ones that you were talking about, the traumatic brain injury and the CVA patients, most of them get tracheostomized in the 5th or 6th day. And how does that change the evaluation in the post-op, the follow-up period?
That's a great question, sir. So, first we need to know why the patient underwent tracheostomy. If tracheostomy was for prolonged ventilation, tracheostomy changes some amount of dynamics in swallowing. Or was the patient tracheostomized because he was aspirating and coughing subsequent to that? Now, in a case when we're dealing with airway and swallow, we treat swallow first and let the airway be. Until and unless the patient swallows well, we are very sure that the patient is not aspirating or penetrating. We do not decannulate such patients. We wait till the end. Now, how tracheostomy, if the patient has just been tracheostomized for ventilation issues, and dysphagia has been all okay, there has been no dysphagia and the patient has been swallowing well. On either of these studies, when the patient is undergoing feast or DFSs and the swallowing is seeming to be okay, we need to deflate the cuff of the tracheostomy tube, number one, and check for the subglottic pressure because that plays a very important role. Also, tracheostomy sometimes decreases the laryngeal elevation in such patients. Keeping all of these things in mind, so it's first the swallow and then the airway.
And the other thing is, when do you deflate? When do you decide to deflate?
When we are checking how the swallow is. Patient is okay with the swallowing, we deflate and then check for the swallow as to what's happening.
The other thing that I wanted to know is, most of the times when these patients tend to aspirate, we put in a rice tube. The nasogastric tube will always be there when you do the evaluation. How does it change?
It necessarily does not change any kind of dynamics. It's almost the same. And ideally, it's not recommended to keep that for more than three weeks.
The next question is, sorry I'm taking a little bit of time. Do you find any difference between the CVA patients who have a hemorrhage and an ischemia? You said the size does not matter.
Yes. So there have been a lot of studies that have been done. When you compare, nothing is different really. It's the site of the lesion that is very important.
Thank you.
Thanks.
questions from the audience?
Thank you, Dr. Farah.
Can I ask you one question, sir? We see a lot of patients with neurological dysphagia. The general dictum we have is delay the PEG as much as possible. You know, the worst is yet to come. Do you know, have any criteria when we switch over from oral feeding to PEG? Is there any standard format that we say, okay, this is when we have to go for PEG, or we continue oral feeding? Because obviously the family is very upset the moment you say PEG. So you have any criteria that we use?
So, we would have put the RT for the patient because of dysphagia, sir. Like I said, we would not want to keep an RT for more than 3 weeks. Now, once these patients are in the ICU, like how physiotherapy rehabilitation begins, our recommendation is to assess, do something called a swallowing assessment bedside, assess how the patient is drinking, eating, whether there is a real necessity of doing a non-oral transport of food or not. If, say for an example, it's a patient of brainstem CVA, and we know that this patient is going to take quite some time, and we really don't know how long till the patient will be able to swallow. Like we are looking at 1 month, 2 months, 3 months, sometimes even years together. Then it's better that we counsel the patients about the PEG. Now there is no need for a stigma to go ahead for a PEG. It's very similar to how I would want to tracheostomize a patient. Now there is a stigma associated with that as well. If there is PEG and the patient, we can prevent any kind of aspiration or the patient's oral nutrition is not being affected because of it, it is always okay to start with the PEG and counsel. But initial 1 month, there is no hurry to do any PEG. It all depends on how the patient improves. Also seen is, initially in the ICU, the patient will be very bad. But once we evaluate the patient after 10 days, 2 weeks, they are definitely better at swallowing. Then you really don't have to go ahead with anything.
Arya will cover this a little bit. Miss Arya will cover it in her talk.
Thank you so much.
There are ways of managing. Each one has their own experience, but Miss Arya will elaborate on that.
The question was not for CVA, this is Parkinson's patient. What happens is not the aspiration initially. The volume is the problem. A lot of them come back after 1 week with hyponatremia. That's the problem we have.
I'll explain this once the talks are finished, sir. Is it okay? We can keep the questions towards the end of the talk in interest of time. Thank you, Dr. Farah. The importance of neurogenic dysphagia is basically, if you see, she said 55% of the stroke patients have dysphagia, 60% of Parkinson patients have dysphagia. If you actually think in your mind that almost 55 to 100 patients who come to neurology OP will have some form of dysphagia. So that is a big requirement for the ENT services and the speech pathology service combined to help these patients. In fact, the cost of stay in the hospital because of neurological patients will increase if they have these kind of comorbidities or dysphagia, as I said, pneumonia, and other swallowing problems. And the current dictum is most of the neurologists may not understand too much about swallowing physiology, so they just say give custard the first few days and send them home with an issue. But patients are wanting more and more quality of cure as such. They want to leave the hospital, be more independent. They don't want the carers to constantly keep taking care of their patients, because carers also need to go back to work. So you have to keep this in mind, and that's the importance of having a symposium like this to create awareness in terms of ENT surgeons and speech pathologists working as a team to help patients with neurological problems and even children with neurological problems. So this is just a brief overview what Dr. Farah had given, and any more questions, please keep in your mind. We'll try to discuss them towards the end of the 3 talks, so you have a complete understanding of all avenues of dysphagia. So the next talk is by Professor Subramanian. Already we have introduced him. So the reason for this particular talk is what are the surgical interventions we can do in terms of rehabilitating dysphagia patients. And Professor Iyer has been doing this since I was training with him much longer before that. There's a small operation theatre in Amrita where we only do these kind of procedures, tinkering with our patients who have swallowing problems. And what that tinkering terminology we do is come up as a proper surgical thing. We have a couple of surgeries which we use and which is commonly also used for other voice surgeries and other type of head and neck surgeries. and we can apply this to help our dysphagic patients who are refractory for regular swallowing rehabilitation. The ideal thing is to put them into swallowing rehab. If they're not improving and you feel you're stagnating, you're dependent on the tube, maybe you can intervene and see. And that's what Dr. Sanayal will be talking about. Sir, I hand it over to you.
No, thank you, Vijay. See, again, my talk is on, see, another one reason which we kept this talk was that it will be more interesting to surgeons also, that we can do something in swallowing. My Dr. Kasi and Dari are going to talk mostly on other things. So, now, this is a term coined, I think by Jayakumar had coined this whole term. We are indebted to him for getting this, in fact, a branch of swallowing therapy also on in India, which we have been working together. It's basically the surgical management, if you look at it, it is has a very minimal role in the management of dysphagia. But definitely there is a good role also. That is what I want to emphasize in this talk. And then when there is a failure of rehabilitation and conservative management, when there is a life-threatening aspiration, or if there is necessity for supplementary rehabilitation in a long term, in certain conditions, surgery becomes important. So I wish just take you through what are the areas where a surgical intervention can help in this thing. Again, this, as I told you, the term was coined by Jayakumar in his paper, and then we have taken it. Surgical deglutology or phagosurgery is something which is a new term. Where it is basically evolved by consolidating all the surgical techniques that are available. It's nothing new, in fact. If you look at what I'm trying to talk and about the techniques, there is nothing new. But it's basically consolidating the whole thing into a concept of a thought process of making it in a consolidated fashion. So now, what is the primary concept? Concept is that you retrieve or augment the swallowing function when all the therapy failures by Arya and other people fail, and then you have, your certain concepts are that you are going to improve the sphincteric mechanisms or the velopharyngeal, velopalatal, glottic and upper respiratory sphincters by some way of other. Then you are going to reduce the extra or intraluminal obstruction by some method, or correct the anatomical problems or bypassing the affected area of deglutition. So these are the basic concepts of surgical deglutology, which I said we are going to use a lot of techniques that are available and that are being used. And lastly, protecting the airway by some method when it's an intractable aspiration. So this will summarize the whole concept of phagosurgery. And then I am going to talk to you about in a way where these are segregated into anatomical areas of problem and what is the pathology and what is the procedure we can do. This I will come one by one in this. Mostly all these problems are either surgery or trauma, or mainly it is when it is surgery, mainly it's a head and neck cancer surgery. So this term was coined by Vidyalan about the oncophagosurgery, which is also important because a lot of things which we do are related to phagosurgery in oncology. So again, my thought process will consolidate that terminology. We are talking about long-term periods of treatment. Why do you have to embark on major procedures? Because you cannot leave rice tubes and other things for long time. This is a laryngectomy specimen where you can see the indentation of a long-term rice tube. So don't think that it is not causing harm. It can lead to ulcers, it can lead to severe pain. The moment you remove the rice tube, patient subjects become much better with reduce pain and those things. So now converting to PET, like the question which was asked is significant, which I have to deal with, and then resort to surgical measures. And then we would always advise using a softer tube like Africa. I'm not promoting that brand, but something like a silicone tube if it is a long-term one. Now coming to these are the things which I am going to talk about. Let's see again based on the pathology. And now look at it. Unilateral. This is the unilateral laryngeal incompetence, usually caused by post-thyroidectomy or skull-base surgery. And then we have procedures like injection pharyngoplasty and medialization. Bilateral laryngeal incompetence is usually post-thyroidectomy or late effects of radiation, where the procedures.
Excellent presentation. It gave a complete overview and swallowing rehab. To our chairperson, sir, do we have time for a few questions? Please.
Of course.
Yes, sir. So I'll start off with answering the first question Dr. Balakrishnan sir had asked. He answered. So with regarding to Parkinson's, sir, you are asking regarding when to remove the Riles tube or how long can you keep the Riles tube. There are, as Arya was saying, the swallowing process itself is dynamic. Each one is individual based. That's what every field now we are trying to individualize our approach to the patient. And you know that there are multiple muscles working in coordination. So in case of Parkinson's patient, how I would approach is that I would actually talk to the neurologist along with my detailed history and investigative assessment. Speak to the neurologist whether the Parkinson is a static Parkinson or it's a progressive. If it's a progressive type of Parkinson's, then I would actually tell the patient relatives to prognosticate. Basically, I would be planning the rehab in my mind, prognosticating when the patient is going to be free from the tube or never. They basically depend on one particular diet consistency. If it is static Parkinson's, then I would intensify my rehab and try to get them off the Riles tube and not even think about PEG. If the progressive Parkinson's confirmed by the neurologist, then I would actually counsel the patient to go for a PEG, maybe maximum wait at least 3 to 6 weeks, and then go ahead for the PEG. So I hope that answers your question. And is there any more questions for any of the speakers? And ISR has to leave, so I can take any questions or I can answer the questions on behalf of ISR. Sir, please do feel free to ask any more questions.
With regards to the swallow therapy, I have great regards for the kind of work that the speech pathologist does. It's really tasking, and I know the kind of effort one has to put in to make the patient and the bystanders understand the kind of effort that they are putting. The one question is, how do you keep tabs on when you ask the patient to come back and do the follow-up after the patient gets discharged? Do you check on them how well they are doing after they get discharged? The kind of instruction that you give has passed on to them, and how do you confirm that, and do you have a schedule?
Yes, sir. So in 2012, when we started the Amrita Swallow Center, we had only one swallowing pathologist there. But now we have 2 staff and more than 20 students working with us. So it's easy for us to do teletherapy reviews. We have teletherapy, telemedicine services in Amrita. Other than that, we have started following our patients using our students. We call them and we inquire about them. And most of our patients are happy with that also. And the patients who are from far off places, we have SLPs nearby them. We recruit the SLPs to monitor the patient status. So follow-up with the patient is lost only when the patient lost stop in treatment. So we make sure that the patient still knows what is the next step. So we explain them. Basically, educating the patient is the easiest method of management. So that they don't have much life.
And what would be the minimum GCS that you require to initiate a therapy for a patient? That is a common question that what are the minimum basic GCS that you have?
Yes, sir. So when we go for the bedside evaluation, we go through the sodium levels and the patient's basic cognitive levels also. So GCS for neurological patients, it keeps on varying on daily basis sometimes. But in head and neck and other patients, it's somewhat stable. So in head and neck patients, we start with the GCS score more than 6 or 7, we can start therapy. But neurological patients, daily we have to monitor GCS, and based on that, we ask them to try oral stimulation.
when it is dropping, we start to do oral stimulation that was safe for the last day because it keeps changing for them. It's a dynamic process.
Apart from the fact that you have the tracheostomies and the NG tubes, this also plays an important factor. Is that what?
Yes, sir. Because on daily basis we monitor their temperature also, because we don't know because of which infection they got this temperature spike today. Because we may be a reason because we force on starting oral stimulation for the patients. It's depriving oral swallowing physiology. That process has to be continuous in the patient. So just to make sure that they are involved in the process, we try stimulation, but with the maximum is 1 ml, just to avoid the this, avoidance of feeding pathway through oral cavity sometimes blocks our services. So for that reason, I stimulate the patients, but I see like it is only safe for the patient under instrument evaluations.
One more question just to Farah. What is your, personal experience on patients who have electrolyte imbalance and swallowing difficulty? Have you encountered?
Quite common. But the thing is, with electrolyte imbalance, there are many other issues that the patient is going through. So the last thing that comes to an intense in his mind is dysphagia to the patient. It's completely reversible. So we have not seen any permanent visit unless and until the brain has got involved and the patient has gone into ischemia or anything of that sort. We wait, we allow the intensities to take over, get the heart, get the body under control, and then immediately when they're out, we just do a swallowing assessment. Most of them swallow well, frankly speaking.
So if you're asking about refeeding syndrome,
Yeah.
so that is basically most ICUs and big hospitals, the intensives takes care of the feeding. So during that time with the dietitian, most of them will be powder, protein, high protein foods. The time when they switch to ward where the kitchen feeds are given, at that time there will be a drop in electrolytes from the dabba of the powder feeds to the kitchen feeds. We need to be very aware of that. We need to keep an eye on the electrolytes, sodium, potassium, all that, because they will go into this confusion, disorientation, and people may mistake it as ICU psychosis or something like that, or psychiatric. So that thing we need to keep in mind. Work closely with the dietitian also.
On which method is useful for the patient, which method the patient can do by themselves, and again that is verified under the instrument evaluation, because sometimes blindly doing a head back can cause aspiration because there is no proper control of the bolus. So we have to make sure that the instrument evaluation has to be done along with the planning of the rehabilitation, which will be safer for the patient. So we started using artificial thickeners to make sure that these thickeners was properly on the IDDC levels, because in most of the hospitals when we advocate for particular consistency, then the food that is brought to the room for the patient will be not in the consistency that we advise, because there is different consistency like mildly thick, moderately thick, and thin also. There is mild thin, moderate thin. So this method is easy for us to identify and make the desired consistency. This can be done quickly, and we can store this food for more than 24 hours also. But there are clinical researchers who shows that there is no much output after using thickeners, because thickeners don't really improve the quality of soil, and such literatures are there. But the methodology we are just going through again. So when we are trying to the bedside, we are making sure that the patients always keep a diet chart with them. So what content they take on what consistency, and how is their behavior after that. Even for the pediatric, we are following the diet charts. So when we say direct and indirect swallowing therapy, indirect therapy always focuses on exercising of the structure. So it is for the improving the muscles of the structure alone. And in direct therapy, it is improvement of the swallowing with an act of swallowing itself in it. So we have to use a footballers while using a direct therapy. So indirect strengthening of the muscles. Usually the physiotherapy principles that we follow for indirect strengthening of the muscles gives a lot of manuals for laryngeal, oral and other neck structures to improve their strength. And the rehabilitation exercises requires the patient participation. So we can do only, these exercises can be only done for patients who are generally healthy enough to practice our instructions and follow these comments. So fees and MBS or modified Berlin swallow, they are instrumental evaluations for swallowing, but we use it for therapeutic purpose also. So fees and therapy, how we use it is under fees, like biofeedback mechanisms can be used. So under fees, we try therapy to make sure that the patient is also getting benefit on a daily basis. So for fluoroscopy is also not just a diagnostic method for me. We use it for intervention purpose. Neurodeglutology is a very vast area and I have already covered that area. But when it comes to a low GCS patient with poor head and control and the patient is in ICU, it is not so cooperative for us, having drooling and a lot of postprandial aspirations. The patient is on intubation, on tracheostomy. So these are the conditions which make us very difficult to manage an ICU patient who is having a neurological background. So the challenges of the therapy for a deglutologist will be based on the evaluation. We find out if the patient is not having a good compliance with the therapy, the patient and the bystanders don't have the ability to follow up with us. If they have no motivation, they have cognitive problems, difficult to memorize the instructions that we have provided, then it becomes a difficult task for the swallowing therapist to deal with the patient. But there is something more that I have to highlight regarding hyposturia. The skill set of the clinician is important to identify at which level I have to interview the patient, at which level the service has to be aggressive for the patient, and having a good team with us to work on. Having a good team who can supplement and collaborate with us. And in nature of the swallowing deficit, it becomes difficult when the patients, because the stages of swallowing is so sequential. So if one stage is affected, the next stage is definitely going to be impaired. So the swallowing mechanism is interrelated and continuous. In that aspect, the nature of swallowing deficits adds up more hindrance for swallowing rehabilitation. But there are several traditional dysphagia therapies given for the neurological disorders which is in the literature. But it depends on how much you can work on the patient. Those patients who are under our supervision, who are admitted inside the hospital sector can undergo this kind of listed techniques of swallowing therapy. But how long will you get admitted under swallowing supervision? So it is difficult to practice at home by the bystanders if they are not well motivated and trained to follow up all these set of exercises for their patient who is actually aged also. In terms of head oncology rehabilitation, when we speak, it's more about the structural problems causing the functional deficit. So there we have to know the physiological area of the component that is affected in the swallowing, and based on that we have to provide the swallowing rehabilitation. In the pharyngeal stage, when as I said, in the fluoroscopy and endoscopies are used as intervention purpose. For in this patient, when we saw the larynx is not so competent enough for feeding, but in later view we can see that they have their own self-compensatory mechanisms, and what we have instructed them has perfectly worked out. As you see in the video, the patient don't have a nasogastric tube and they don't have a proper laryngeal strength also, but this patient is managing to swallow thin liquid without aspiration. So in oral transport stage, in this video you can see this is a post vasectomy patient with mild oropharynx is also removed, but this patient is managing their techniques for swallowing. For a safe swallow, this patient is at NGT also. But fluoroscopy is the gold standard for swallowing assessment, but not the last word for swallowing assessment. We have to combine clinical instrumental evaluation findings and our clinical skill sets to improve the designing of the swallowing therapy. Because swallowing VFSS will not give you the whole idea for the patient. You have to sometimes combine VFSS fees and the compliance of the patient, medical background, everything together to design the swallowing issues. And not one technique will provide all the help for the patient. We have to take whatever required from the patient side. It should be a tailored approach. I can't just follow the indirect exercises, or I can't just switch on the compensatory methods for a patient. I have to choose all those tips and exercises which is good for my patient, and it's tailored and practiced, and make sure that this is what we have to do. Then only we will allow them to follow. So we are working close to the Government Cancer Center in our place also, as volunteers we deal with the patients there. And in head and neck, rehabilitation is also very important, because we know all our patients after their diagnosis goes through a lot of traumatic experiences in terms of the treatment as well as the consequences of the treatment. So rehabilitation for the deglutologist includes the motivation, counseling and pre-treatment itself, because after the POD, when they have all the tools and they are paying because of these procedures, they won't be they won't be providing good support for me to work with them. So if I meet them before their treatment and we have good compliance with the patient, teach them the exercises prior to their treatment, that helps us a lot, because we have now rehabilitation continuously running in our pre-radiation patients, and we found that most of the patients are able to postpone their NGT insertions